I'd like to introduce our speaker for today. Dr. Robert Noecker is a leading ophthalmologist at Ophthalmic Consultants of Connecticut, specializing in the medical, laser, and surgical management of glaucoma and cataracts. He has more than 20 years of experience in developing innovations in laser and glaucoma surgery and has conducted over 50 trials on the pharmacologic, laser, and surgical treatment of glaucoma, macular degeneration, and dry eyes. He has also performed many preclinical studies on laser tissue interactions. He's on the editorial board of 10 peer-reviewed journals in ophthalmology, has published over 100 peer-reviewed papers, and has lectured around the world in over 30 countries. Ladies and gentlemen, Dr. Robert Noecker.
Okay, thank you, Mike. And thank you all for coming out today. So we'll spend the next probably 30-40 minutes just covering the content here. It looks like we have sunshine outside, so it'd probably be good for all of us to get out of these dark rooms for a little bit. So today I'm going to talk mostly about micropulse technology. First, talk about what it is, how it kind of works, a little bit of the physics behind it, but not too much. And then we'll talk about the two applications where it's really relevant in glaucoma care. And this technology has been used in other parts of ophthalmology already, so in some ways it's not new. What's new is the application for lowering eye pressure or treating glaucoma. So it's something that I've been involved with for probably 6-7 years. We did some early animal work and early patient work, and I'll kind of interject my anecdotal personal experience throughout as we go through the data. So you have any questions you want to get covered off the bat? Any burning issues before I start? Okay. So I'm a consultant for Iridex who's sponsoring this. And so first we'll talk about micropulse laser trabeculoplasty, but first is talk about micropulse. And so there's multiple different strategies with lasers to keeping damage down or keeping the temperature down. You know, and this is where the concept of cold laser technology comes into play. So one way to do it is to basically collect all the energy, do it in a very short pulse, and then turn it on and off very quickly. And what we do in micropulse is we chop up the laser energy, because if you just hit the pedal with a visible wavelength, which is what this is, it gets, in this application, what we're doing is we're targeting pigment. So it gets absorbed by the pigment, and then the heat just, there's nothing to stop it. So it just kind of keeps getting warmer and warmer. And if you do that, you get a burn, and then you get coagulative necrosis. And you know, the contrast, and we'll talk a little bit about that, that's what's going on with ALT, because what we're talking about in biology is you really want to keep the pulse, the active time down on the order of nanoseconds or microseconds. So, and if we do, like, for instance, ALT, that's 0.1 seconds usually, that's a lot of time for biological tissue. So that's why you get heating, that's why you get burns in other applications. But with micropulse, you basically turn the energy on, but you switch it on and off very quickly. So you're getting the energy delivery, but then you're shutting it off before the heat can start to build. So you get the therapeutic effect that you want, the laser tissue interaction, but you don't get the downside. So nothing in life is free, but that's one way to make it as free as possible. And then what happens is you are causing a limited injury. So any cell that contains pigment will be targeted, and you'll have absorption. And that cell, if it absorbs the laser energy, will basically die. And in the trabecular mesh work, that's actually a good thing. So if you do it on a very limited basis, you will recruit monocytes, and monocytes are what you want, because those are the cells that have receptors for cytokines on them. So you have limited damage, cytokine release, recruits monocytes, which become macrophages, and that is what the cell that does the IOP lowering, much as we see with prostaglandin analogs, but also with laser trabeculoplasty. So we have all these biologic factors that basically start this biologic cascade. So you want to do the minimum possible that is to turn on that cascade, but then you want to stop before you have unnecessary damage or coagulative damage. And that's when you see, you know, an illustration of this. I don't know if everybody's done ALT, right? Or many people have. And so if you look back, you know, and I look back at my own that I did probably 10 years ago, because I haven't done ALT for a long time. But you look back, and invariably there are peripheral anterior synechiae in these angles of people who have had ALT. That's one of the ways to tell that they've had ALT, not necessarily during the treatment, but afterwards. A lot of them will have peripheral anterior synechiae, and that's from this thermal damage and then the coagulative necrosis that basically has led to chronic scarring. And you won't see that with micropulse. Part of it is during the treatment you don't see much, and afterwards you don't see much, which is overall a good thing. So once again, micropulse has been used in ophthalmology for a long time. It was first developed and really most studied in the retinal space. And once again, when you're treating things, especially in the macula, you're applying low levels of energy, but once again, you're not getting heating or burning. So during the treatment, you don't see that much. And for diabetic macular edema, other RPE targeted procedures, you can basically get a limited thermal effect with a mild insult that produces the favorable biologic kind of responses, but you're not leaving a scar. So that's very attractive in retinal world. You don't want to have scars on your retina, but it also could be attractive in the trabecular meshwork as well. So this basically technology has been borrowed from the retinal space and kind of optimized. The first laser that I used was the 577, or the yellow laser, which has a little deeper penetration depth, and that's kind of an ideal wavelength for retina. It works for glaucoma, but it's probably unnecessary to penetrate the eye, the trabecular meshwork that deeply. So we see more and more, where does laser trabeculoplasty as a whole fit in? And I think in this world of, I should say, oppressive managed care, economic challenges, that every day we have patients who are limited in their ability to medically treat their glaucoma, or what was working fine. We had a great, say for instance, branded prostaglandin analog they're being perking along on, and all of a sudden they can no longer acquire that for whatever reason. And so laser trabeculoplasty is something that I think in our environment has been used more and more at a practical level, but it also makes a lot of sense to use it. And in my practice, I do a lot of laser trabeculoplasty. It's something I talk to my patients about right up front. I usually tell them that they're probably going to need both medical therapy and laser trabeculoplasty. And when we set that expectation, I think it's well received. So, other types of laser trabeculoplasty, ALT, which is something I no longer do. And once again, it's because you have those same biologic effects that you might get with MLT, but the bad thing is you leave scars. And when you treat with ALT, and I'm sure you've seen these scanning electron micrographs that I've done, where you have these craters, and that's dead. It's dead forever. And that's what makes ALT a little bit dangerous. So in a not so bad eye, you can treat it, the trabecular meshwork, and there's enough viable trabecular meshwork around to kind of the upside outweighs the downside. However, in these marginal cases where you might knock off the last viable part of trabecular meshwork, you can see pressure spiking, and then patients have to go on to surgery. So ALT, it's not so much the efficacy side, it's really the safety side, which we're always just worrying about that patient and we're going to push over the edge. With SLT, which is a newer technology, we studied it since the mid-90s. I've been doing that procedure. And once again, SLT, their strategy with SLT is different than MLT, is that it's a very, very short pulse duration. So it's 3 nanoseconds, much as we do with our neodymium YAG that we use for capsulotomies or PIs. And so they basically have minimal thermal effect in that particular situation because of the short pulse duration. The downside is because you have no thermal effect, you can have some bleeding. You can basically start cascades that are unfavorable, but it definitely has an improved safety profile compared to MLT. So MLT uses the same green light, 532, so it's a double frequency YAG green light that we use in most of our lasers today. There's minimal thermal damage. Once again, you want a little bit, but not too much to get the favorable cascade. You basically, as we talked about a second ago, activate macrophages. A 300 micron spot size, which SLT has a 400 micron spot size, which really on a practical level is sometimes quite hard to get clear of the iris, because with all these procedures there's no good that ever comes from hitting the iris when you're doing the actual procedure. And the 300 micron spot size is a little bit easier to get around that and fit in the treatment zone and not hit the iris. Minimal post-op inflammation. Typically with this procedure, I don't give the patients anything post-operatively. It's repeatable. I have patients I've repeated up to three times with this so far. And the nice thing, once again, we can use this same technology for other applications, and the glaucoma application we'll talk about in a second. So MLT versus medications, efficacy, compliance. There's nothing more compliant than these patients who've had a laser. They don't have to put any eye drops in. Side effects, especially in terms of ocular surface disease, is probably the thing we worried about the most. The cost of acquisition and the simplicity to patients' lives. So these are all favorable speaking points for MLT. So here's a video. Ike Ahmed actually made this video, and you can see the procedure. You see the brown line is the trabecular meshwork. I'll refire this one more time. And you can see the light kind of flashing up on the upper right-hand side. So we're basically, it's very easy. Probably the light only overlaps the scleral spur, the white band there. And we see that the treatment zone proceeds. And once again, like SLT, we want to kind of abut the spots. And I treat 360 degrees, about 100 or so applications over the meshwork. And we'll just look at that one more time. And you can kind of see the light firing. It's filtered, but you can see the green flash kind of reflecting off the lens in the video. So this is a very kind of straightforward treatment that takes a few minutes, and the patients do very well. So here's some SEMs. And that we did a few years ago, and not to, cast a pall on being in Hawaii, but we are here. So these are typically the ALT burns. So these little craters here. And once again, this part of the trabecular meshwork is no longer viable. So the idea is that you have upregulation in the rest of the viable trabecular meshwork, but these areas are dead. And that's why you have to space ALT. So if you abutted all your ALT spots, all you'd be doing is creating a bigger zone of dead stuff. So basically by spacing, that's what you basically are preserving. You do have good areas, even though you've sacrificed a little bit around there. Micropulse, you can see you have that kind of nice lacy architecture of the trabecular beams. You really can't tell anything's done, and it doesn't look anything unlike the control architecture of the trabecular meshwork. So I like these SEMs, and that's why we do them, to kind of prove the proof of concept that, theoretically, it's always nice theoretically that we're not causing any damage, but the proof is in the pudding when we do it in these eyes that we've autopsied. So in terms of efficacy, how well does it work? So we can go over settings, specific settings, or Mike can certainly help us with that, but the amount of energy that you do use, you don't want to do too light a treatment. Once again, that's safe to do at a light treatment, but you may not get the IOP lowering it or the efficacy that you want. But if you treat with 1,000 milliwatts, and once again, most of these treatment times are on 15-second or 15% duty cycles, so most of it's off time. So you set it for 1,000 milliwatts in an ALT world or PRP world or whatever, it's like, wow, that's a fair amount of energy if you're just letting it rip. But once again, you have to remember when you have the micropulse, the laser does it for you. So you hold down the pedal, but most of this is off time. So once again, you're cycling up and down, but most of it's at rest. So you're delivering the peaks of that energy delivery are there, but most of it's, you're using much overall energy. Yes. Yes.
Okay. Can you just comment on the percentage of patients that are actually achieving that IOP reduction 12 months and 24 months?
So typically, depends on, in this particular study, it's usually about 75%, 70 to 75% when you look at the ballpark. And when you look at the response rate, 25 to 30% reduction. So nothing's 100%. As we know, there's non-responders with everything. Looking at the data a little bit differently, this is a multi-center study, and this divided out patients who had MLT, so about a 24 millimeter reduction, and on average dropped the pressure down to 18.5 millimeters, so about a 25% reduction. And when I'm talking to patients, usually the numbers I give them are about 70-75% response rate. So I say 3 out of 4 people respond to this. You may be the 1 out of 4. We'll find out. And expect about a 25% reduction, which if you're starting in the mid-20s, it works out to about 25%. And with laser trabeculoplasty as a whole, the higher the pressure is, the more of an outflow problem the patient has, the better it tends to work, both in terms of percent reduction and absolute numbers. And we see this in a number of interventional studies in terms of glaucoma. So on a par with what we might get with some of our better drugs at 1 year. So in treatment parameters, not to get too deep into this, but the power is 1,000 milliwatts. The spot size we preset at 300 microns. A 300 millisecond duration, a 15% duty cycle, which means 85% of the time the energy is off, 15% is on. We place confluent applications, and once again, the more thorough our treatment, the more trabecular meshwork gets exposed, the more cytokine release we'll have, and the better distribution of the macrophages when they basically come and clean everything up. Typically, I don't prophylax against IOP spikes. I would never criticize anybody for doing that. Also, there are some patients, I think darker patients may be prone, and those are the ones you may generally worry about, and you may choose to do those, but as a general rule, we don't have to. I typically see these patients about 10 days, the global period, not to be a mercenary, but the global period is 10 days with these, so usually about 10 days to 2 weeks, we see them back for a safety check. Typically 6 to 8 weeks is when you get an overall idea of the success and kind of the plateau phase of the eye pressure. Did you have a comment or question?
Just about pigmented trabecular meshworks, lower the power settings.
Yeah, so and especially for, say, like a pigmentary glaucoma patient, when we know they're so heavily pigmented, those patients where you can't even see the scleral spur, there's so much pigment in the area. I think it's wise, and those I'll basically go down to like 700 or 800 milliwatts for the treatment. So I do adjust. These are pretty average settings. Like this is what we start with, and the truth is, even on the low side. So we say, what if the trabecular meshwork's really pale? The truth is, there's pigment in there somewhere. Unless you're an albino, there's pigment in your trabecular meshwork, so the laser will kind of find it and target it, and that's okay. But on the heavy side, you do worry about just having too much absorption. The good thing, and this is kind of where it contrasts a little bit with SLT, is because there is a thermal effect, you tend to get less dispersing. Because SLT has no thermal effect, what it hits, it kind of scatters. And that's kind of the danger in pigmentary glaucoma, is just, you can fill up the eye with a lot of pigment pretty quickly. And that's why those patients are at higher risk for spikes. So that's a little bit of a contrast when you're looking for pluses and minuses. But that said, I do tend to back down, because you always can do more.
Are you also looking for a tissue reaction? So
No, it's one of those procedures where you do it on faith, and which is somewhat frustrating to us, but that's okay. I like seeing nothing. As I've gotten older, seeing nothing seems like a good thing every day. Being bored is not a bad thing. But there's zero done properly. There's zero feedback. If you're seeing something, then we should probably question why you're seeing, because there really should be zero visual feedback. There shouldn't be any bubbling or blanching or anything. All right. So in practice, where's the role? Efficacy. Drugs. We have some great drugs these days, but now we have patients who've been on medications for 20 or 30 years. That's not that uncommon anymore. And they just over time, there's, for whatever reason, upregulation, progression of the disease. I tell all my patients, you're going to be on medications and you're going to get laser treatment. Just expect to do it. We hope the changes in our interventions will be slow and spread out over years. But that's what it's probably going to take over time. Most people need some kind of change in therapy over time. People who have failed, I've had patients who have failed previous SLT and or ALT, and we've gotten a decent response with MLT. I feel comfortable pre-treating over previous ALT procedures. These patients are largely going away. This used to be probably a bigger issue, but also prior failed SLT. So I look at this as probably a little bit more potent than SLT. So if it fails and I really want to do laser trabeculoplasty, I think it's nice to have this as a tool. And once again, there's some patients, I usually tend to start people on medical therapy. I think that's what most people choose to do, but there are other people, I can give them a prescription for whatever, and it's going to end up in the garbage can outside on the way down to the elevator. So I think, there are some patients that primary treatment is something that we do more and more. Yes?
How many points do you expect on pressure lowering with the laser?
I typically say, I usually, just as the study, my experience is consistent with the study. So say pressure is 20 and 24, I expect like a 25% or 6 millimeter response.
30, don't waste your time.
No, I think if you look at the data, 30 is not a bad thing. But if you want the pressure from 30 to 15, this is not going to do it by yourself. And this is kind of the art of it. And this is why I tell patients, to expect both. But do I think I can get this with one of my prostaglandins and do that? Yeah, I think that didn't used to be possible, but I can knock you down between a couple therapies. I think I can do that. But by itself, it's not going to whack it from 30 to 15.
Can you do it over MIGS?
I can do it post MIGS.
Yes. Okay.
I've done it post failed or marginal, trabeculectomy. So if you have open angle, the one criteria is you have to have open angle, and yeah, I've done it over a few eye stents, and it's fine. Yes.
How does this compare to SLT versus efficacy? And also, have you ever done it on top of SLT, like an additive effect? Is there any possibility of an additive effect with SLT or vice versa?
Yeah, I'd have to say that's a good question. So I think the most common scenario is you've done SLT and you're just satisfied with it. Let's put it that way. So maybe it's not a zero response, but it was an under response. And so I've done this over top, and I've gotten, like, say I wanted my 6 millimeter response, I got 2, and then I've done this, and then I've gotten the 6 out of it. So I think it's a nice tool to have for precisely those situations. I think in a de novo patient, I think the IOP lowering is very similar. So like somebody who's never had anything before, I think I expect about the same as SLT. Yes.
And just a question about it being repeatable. Do you wait the 6 to 8 weeks, and any time after that, if you haven't achieved the response, then you would consider repeating it, or what's your approach?
I think so I think the lesson is that if you have a 0, then this is just not going to happen. And there's a number of reasons that have to do with your macrophages, but it's just not going to happen. So I think the next thing, if you get a partial response, and I think the lesson with this is for better or worse, this lack of visual response. I'm fairly compulsive with this, but you always miss. There's parts that you say I am treating 360 degrees, and I know I did it perfect, blah blah blah. But if you really go back and criticize yourself, you turned the mirror too far this way, or you got confused, or somebody talked to you in the middle, or the patient coughed, and there's often a lot of skip areas, and I think that's the rationale to go back and retreat. And I think it's safe to retreat over the area to try to push out the last couple of millimeters. And I think that's a viable thing to do. So yeah, so decision times at 6 to 8 weeks, was this good enough or not? I think for people who had a good response and it kind of fades away, probably 6 months is the earliest I've treated it, but usually it's a year or two, on down the road if that's what we're doing exclusively. That's a good question. Yes.
You've done an iritis patient and they're on steroids. Does it work? I mean, there's really nothing that works on them.
Well, if you think their pressure is up from the iritis, I would agree. If you think it's up from the steroids, I would say that the laser trabeculoplasty is actually a very good thing to do, and arguably the first thing you probably should do. So if you had patients, so it depends how quiet they are is the bottom line. So if they're like all inflamed and tons of cells, then yeah, it's probably the iritis more. If they're pretty quiet, but you have them on steroids and you need that for the inflammation, but their pressure is going up, laser trabeculoplasty, actually this is a good thing to do. And once again, it's because you get that benefit of the macrophage upregulation. Because what steroids do is they basically, you have an increase in extracellular matrix proteins and other material from the trabecular endothelial cells, just not pumping as they do normally. And so what you want to do is you can clean that out with macrophage recruitment. So if it's a steroid response, I would say this is a good thing to do. If it's just inflamed, yeah, you got to move on. Good question though.